This is PT Pro Talk, the podcast for physical therapists who want to improve their clinical skills and be more successful. I am Mariana Parks, physical therapist and your host, and today I interview Luke Bongiorno to discuss pain and the neuroimmune system. Luke is a physical therapist and the director of Noi Group, taking over from David Butler and Juliet Gore. He is the co-founder of New York Sports Medicine, manages professional and Olympic athletes, and serves as a consultant for the NBA League and European professional soccer teams. In our discussion, we talked about the role of the immune system in pain, how to influence the immune response, the role of PTs in the process, and how to address pain and the neuroimmune system with our patients. If you find this information valuable, I encourage you to subscribe to our channel, click on the notification bell to stay updated, give us a thumbs up, and share this content with other clinicians you feel may benefit from it. Thank you for tuning in, and we hope you enjoy the show. PT Pro Talk is only possible with the support of the forward-looking and innovative companies like Systems for PT, the Do Anything, Anytime EMR. Systems for PT develops systems for clinics so you can focus on your patients. Go to systemsforpt.com to schedule a demo today.
Looking for the highest quality equipment for your clinic? Turn to Fitter First. Our wobble, rocker, and slant boards are all assembled in North America to meet the demands of a busy professional clinic. Designed to adjust in seconds and made from the highest quality materials. Get the best Canadian-made rehab and balance products for your clinic. Order online for your clinic or for your clients. Ground shipping anywhere in North America. Visit fitterone.com. That's F-I-T-T-E-R, the numeral 1.com.
Hi, Luke. Welcome to PT Pro Talk. How are you today?
Hi, Mariana. I'm well. Thank you. How are you?
I'm well, doing well. Estou bem.
Estou bem. Eu falo português. No, not really, but a little bit.
Yeah. You can play a little bit with Portuguese, so that's great.
My favorite place to teach.
Oh, yay. Awesome. So look, let's start talking a little bit about yourself and your background.
Well, my name is Luke Bongiorno. I'm a physical therapist, a physiotherapist from Australia. I'm actually currently in Australia at the moment. I grew up here and trained here, and I've lived the last 25 years in the US. So I'm based in New York, and I have a practice there. And I'm also teaching for Noi Group, and have recently taken on a director role there over the last couple of years. So I love the topic that we're talking about, and I still love I love to teach and I love to practice. So this is me. I grew up from a large family, so.
I was reading about that. I am from a large family as well.
Oh, really? What number are you?
I am number 2 of us. We are 6. So.
Oh, wow. Yeah, I'm number 4 of 9. So
wow.
It's
good.
So you got a little bit of responsibility taker honorers. Yeah.
Yeah. It's good to grow in a big family. I think so.
I think so too. And it teaches you, I often tell people that when I'm presenting a course, or because what it does, it teaches you how to play different roles and conflict management, which as a clinician is really useful because we often have to present material in a different way or something that's maybe conflicting with information for our patients. So
you have to learn how to live with a lot of people around you.
Yes. And negotiate and be heard and listen and be heard. Have influence.
Yes, very true. And also I have to thank David Butler for introducing us and connecting us so you can carry on the knowledge here and share with us.
Yeah. I'm very lucky. I mean, I'd like to acknowledge David, and who founded Noi Group, and he worked a lot with Professor Lorimer Moseley. And I consider myself as a clinician very, very fortunate to have spent a lot of time with these people as well, and a lot of the team down in Australia. So I'm not a researcher, so it's really good for me.
What a privilege, huh?
Yeah,
Very,
definitely.
yes. Okay, so our topic, it's a little bit complex between the papers, and let's see if you're going to make it simple for us. The neuroimmune system science. So let's start talking about why you say that's more appropriate to refer to the nervous system as the neuroimmune system.
Well, this is a topic that's really grown over the last maybe 15 to 20 years, is neuroimmune science. I remember David Butler introduced it to me 20 years ago, and I really didn't know what he was talking about. What I've learned is that, what we've learned in research and science is that every neural synapse has cells with immune function. I think in the glia, the number of immune cells or glial cells in the brain, for example, is like 50 to 1. So there are so many synapses, and this is part of the reason that pain and how we respond to different stimuli is so complex, because of the connections and the immune connections and how these things communicate. So while we used to have a course, mobilization of the nervous system, we've now changed it to mobilization of the neuroimmune system. And and that's a way also we can communicate to patients, is rather than thinking of just nerves as being their own entity, tying it into an immune response can be a nice way that we can communicate this information.
Okay. But can you say that how they are connected? You said that like in some neurosynapse cells, you have some cells with immune function, right? So how is that relationship? How does that work?
Good. It works by, we know that we have nerves in our system. When it comes to pain, we think of nociceptors, that transmit messages from the periphery through the dorsal horn, spinal cord, up to the brain. And we have ascending and descending pathways. So now those nociceptors have a cell with an immune function. So say, for example, a glial cell. What happens is when we have some sort of threat or danger, might be a pathogen or a virus, this immune cell is activated and it releases chemicals. Nociceptors are responsive to movement, to thermal stimuli, and to chemical irritation. So what it does is when the immune cell is active, it triggers that nociceptive to send more messages up to the dorsal horn and spinal cord. So essentially what's happening is it's creating hypersensitivity, and that can signal to ultimately resulting in the perception of pain, with or without tissue damage. Yeah.
Okay. And that's the role of the immune system in pain?
Yeah, that's part of the role. It's a highly complex, and I don't understand it as much as I probably should even. However, that's part of the role. And what happens is this becomes, we have immune cells not only in the periphery, but also in the spinal cord and in the brain. Many are located in the hippocampus, for example, and the amygdala. So that makes sense. If you touch, a hot stove, you have cells in your memory. Don't touch hot stove, Or if you think about someone in pain, last time I walked, I had a lot of pain. So walking might send their immune system to become more active. Does that make sense?
Yeah, it does make sense. Okay. And how can we influence the immune response?
We can. I mean, you can't think your way out of pain. Sometimes we think, all right, it's mind over matter. And I have this issue with patients. We think of pain as two things: a physical, something is wrong in the joint, but zooming out and looking at the big picture and saying, right, pain is a defensive response. Sometimes I say pain is a defender, not an offender. So again, this is a simplistic way of viewing it. However, when we're communicating to patients, we can't get bogged down in the science. And even as clinicians, we can drive ourselves into an anxious state if we try and understand every little bit of the complexity. However, just moving the patient's understanding or shifting our own understanding from pain equals there must be damage in the tissue, for example, with elbow pain, to, I see that I had a fracture in my elbow 6 months ago. There are going to be cells there that are serving to protect me if I extend my arm or move my arm too much, for example. So essentially our goal or the target concept for our patients is to shift their attention from there's something wrong here, my elbow hasn't healed, to, okay, I may have some issues there in the tissues. However, why I'm finding it hard to extend my elbow is because of a more complex series of events involving my immune system. It's there to protect me. It's there to help me because I had an issue there in the past. It's based on what we think and believe, our past experience. It may not be just with the current injury, but it might be something might have happened 20 years ago, 30 years ago. And we still have those cells locked in there in the brain.
Yeah, so for let's say for us as PT, what's relevant is understand the process and know how to effectively communicate and educate the patients.
Exactly.
Yes.
Yeah, I think traditionally, a lot of, again, the work by David Butler and Moseley has sort of been in contention over recent years because we think of Explain Pain, which was the original book, as us as therapists telling to the patient, this is how pain works. Now, that can be very confronting for a patient, and it can actually lead to some negative outcomes. If a patient doesn't feel heard, they don't feel understood. This is more about, as a clinician, I think it's our responsibility to understand a little bit more about it, a little bit more about this is a complex, pain is a complex series of events that does involve the immune system. And then we can communicate, we can choose the words to use, and we can also adjust our responses as a clinician so that we can communicate, as you said, effectively to the patients. We don't want to we want to enhance our therapeutic alliance. We don't want to break it. And sometimes if we're sort of telling them about their pain, that can actually create less effective communication and often less optimal outcomes.
Mm-hmm. Yes. And as we were talking before about the immune system, is there anything that we need to know, that's going to change our approaches with the patients, in our day-to-day clinic? Because it's a lot of complex theory, right? And I'm just trying to translate to practice, what are the things that we should be looking at and that we should know about that?
Okay, well, it first of all starts by, in a clinical setting, I do get asked this question quite a lot. And again, I would recommend some resources for clinicians to educate yourselves. There's another great profession who I didn't acknowledge earlier, Professor Mark Hutchinson from the University of South Australia. He is a really passionate and great presenter. He's got a lot of just videos and he's written some papers. But I would encourage clinicians to take that leap of faith and just learn a little bit more about it. At the same time, in practice, this can be presented even without knowing all the complexities of it. And I've been studying it for 10, 15, 20 years, and I still don't fully understand. What I would say, though, is in the clinic, just knowing that there's a link between your immune system and your immune health and pain can be enough to present this idea to patients. Do you feel that when you have pain, you're doing damage, or do you feel that you're guarding it or protecting it, or is it a little bit of both? So I give them 3 options. So you're actually then inviting the patient to think, yeah, it hurts, but I don't think I'm doing damage. I think it's just pain. And I say, do you notice yourself protecting it? Because I notice your arm is like this, you're holding it. Oh yeah, I do that all the time because I don't want to hurt myself. It's become a habit, particularly in cases of persistent pain. So this is where I can introduce the concept. While we do know there is a link, this doesn't mean you're making it up. There are cells set out there to protect you, immune cells, that create movements, that create protective responses that happen without you even realizing it. I do notice that. It's a way to invite them in that then you'll hear the patient then might come up, their story will evolve. And they might come out with other things. Oh yeah, I noticed that. I noticed my neck gets tight, and maybe you can look at that in an objective assessment, and you can look at range of motion. And when they do, say, for example, some slow breathing, something to reduce their upregulated sympathetic guarded state. Just doing that, I feel like I have more movement. You haven't touched the shoulder. You haven't manipulated it. You've just allowed them to sort of downregulate their system a little bit. And that's how I would do it in practice. That's exactly how I do it in practice.
Okay. So I was reading a lot about mindfulness, right? That the papers are talking about meditation, breathing techniques to try to calm down and then help with the response. Is that right? Like it's more like a holistic approach?
Definitely. Yeah. And I like sometimes with patients, the word holistic, they think, oh, this is like my wife tells me this, or, it's a little bit abstract for them. Because when I don't know if you've had like a painful experience, I'm sure we all have, but when you're in that state, you don't care about that. All you want to do is address the pain. It's very difficult to see beyond it. I remember myself, I was flying to Australia. I was in Los Angeles and I was about to teach a course. My first course I was teaching in front of David Butler. So I was probably a little bit nervous myself. This is maybe 5 years ago, a bit more. And I remember feeling this searing back pain. And in my head, I thought, wait, this has got to be, there's got to be someone said something about a disc. I'm like, wait, what if this neuroimmune stuff is just all wrong? What if they've got it wrong? I could be like speaking rubbish to these people. And all I wanted at that point was an MRI and an epidural, and then I'm like, Luke, calm down. I could feel it in my state. And I'm like, all right, come on, there's enough. Just breathe. And I remember that moment because it gave me a renewed understanding of what patients are going through. And if someone said, Luke, breathe, or Luke, just relax. It's like when you're anxious, the last thing you want to hear is relax. I am relaxed. Don't tell me what to do. You're not listening. You're not hearing. And that's really important, because that's how we can connect to the patient. And sometimes I'll say, look, I'm not going to tell you need to go meditate or you need to breathe. It's like trying to get someone to change religion. You invite them. If they're open to it, go for it. Otherwise, say, look, I'm going to try a technique right now that might help to downregulate your nervous system just temporarily. Are you okay with that? You ask permission. Sometimes I say, of course. I said, are you sure? Okay. So what that means is then in a treatment session, while I'm with them, I'm not going to try and change their behavior yet, but I might say, right, I'm going to give you a very specific task, breathing in, hold it, breathing out. And I'll get my iPhone out with a timer and I'll say, right, we're going to breathe at 5 breaths a minute and do it as part of my assessment. So that way it's a less confronting thing for the patient. You're not going to make them feel bad or shame them that they need to relax. They might have a lot of stresses that haven't even come out they might be going through something, relationship difficulties, issues with their children, whatever it might be. But if you can start by just introducing that and giving them that experience, then asking them, how does that feel? Oh yeah, I feel more relaxed. And when you touch them, I feel that's actually less sensitive. I said, great. That suggests to me that part of your system is now, under feeling guarded. And we've got a strategy now. When you have that experience and when you have that pain, doesn't mean we're not going to ignore your shoulder or your knee or your elbow, your back, wherever the pain is. We're not ignoring that. But we can get more reliable information if the rest of you is slightly in a calmer state. Does that make sense?
Yes, and it's great that they can see the results right there. Like, okay, I'm breathing and now I can do this movement better. So like there is some of it that could be related to this state and they might, start doing by themselves.
That's the goal.
Yeah.
And there are other ways to do it in practice. You asked me, how do I do this in the clinic? And while, again, we're talking about the neuroimmune system, don't forget the fact that can be a very foreign concept for patients. And just showing them maybe an anatomical link to start with. Often they understand things better mechanically. So I might show them a picture of the psoas muscle. I was mentioning earlier, I taught trigger point courses, many in Brazil. Punta Gatilho. Cotovelo, cotovelo, like all the body parts I learned in Portuguese.
Look at you, you're good.
However, but what was interesting to me is seeing the picture, seeing that their hip muscle, their psoas muscle connects to their spine, can help shift their concept to, I thought the issue was in my back, to that muscle is helping protect me. And you can go a little deeper if they're able to do that. But I'll show them a visual image of the hip flexor and then how it interdigitates to the diaphragm. So they see a physical connection. It can help them be reassured, okay, now I have something to visualize when I take a deep breath. So that they're not just, breathing up. I'm like, all right, let's feel this. And you're giving them that's mindfulness. It's breathing. And that's a way we can really tap into our immune systems a little bit more, or the behavior of how our immune system reacts and responds.
And other than these techniques that you just mentioned, is there anything like a more like not therapeutic, that's not the word, like more manual? Is there any technique or exercise, anything more specific that you also use, more like PT specific?
Yeah, a lot. I would still consider myself very much a manual therapist and exercise. So another challenge I think clinicians have, myself included, is that, when you go to these talks and I hear all these really smart people talking about the neuroimmune system and the brain and the dorsal horn, it can be a little overwhelming for me. I think, maybe I'm doing something wrong, or I shouldn't be touching the patients. It's all in the brain. That's not useful. That therapeutic touch specifically can be a really safe and valuable input for the patient. What I will do, though, when I'm doing manual therapy is not just focus on the part that's in pain. I'll get them to become aware of other areas of their body that might be sensitive. Of course, asking permission first, but helping them say, oh, I didn't realize I was tight there. Or they might say, yeah, I do get pain in my leg, but I thought it was a separate issue. I said, well, what happens when you go to protect yourself? What does your body do? And I might get them to see the movement, and they'll say like that, or they'll move their leg at the same time. I said, this happens automatically. Show them a picture that might be confronting, and you'll see the body move. I said, that involves many muscles, but literally hundreds of thousands of millions of synapses based on threat, it's like an immune response, and everybody responds differently.
Yeah. And then you get to work in other parts to try to help relax their body, get them moving better.
You help relax their body. You also help to increase their body awareness. So one other thing we've learned, and there's a great David Butler video on homuncular smudging. We think of the maps of our body in our brain, the brain-bound body maps. So, for example, when we have pain or persistent pain, these maps become disrupted. So a certain body part represented in the brain becomes bigger or smaller. The part of the brain doesn't enlarge, but the immune cell activity around that area becomes more active. So that can do two things. Number one, our perception of where the body is altered. Okay, where the body part is, and even to the point of our center of gravity is moved. If we've always had right-sided pain, we might reject that side and trust more the other side. So our sense of balance is a little off. And then the other part is we're not getting necessarily reliable information. And you can test that in the clinic doing things like 2-point discrimination. So getting some calipers and putting, do you feel one part or two parts? And you might test one side compared with the other. And people, oh, I didn't realize. Yeah, that's weird. They'll say oftentimes when someone's feeling something from the first time, it might say, oh, that's weird. I said, well, the good news is that's not weird for me. That makes sense to me. However, of course, it's different, but it's giving us a reason why. You've been suffering for a long time, so that suggests to me that I'm missing something or we're missing something in the medical community, and my job is to help you find it and help you figure it out. So it's a lovely way to help to show the patient that you're paying attention, and at the same time, they are paying attention to their own body in a way that maybe they haven't for a long time.
Mm-hmm. And by increasing their body awareness, the locations that they feel pain, that helps to calm down their system? Is that the mechanism? Or
yes, one way is to calming the nervous system, because then what's happening, instead of just getting nociceptive information from that body part, you're getting other sensory information. So you're changing the input. It's like, think about it like this. If someone hits themselves, what might you do? If you hit your shoulder, you immediately put your hand over that area. So you're changing the inputs to change the output. When you change input, you change output. That's visual cues. Okay, visual information is really influential in pain. When we see something, just seeing a foot can be enough if someone has CRPS to create pain in the foot without them even moving it. So, and when we tactile information, so changing the input can change the output, and that's what you're doing, or that's what's happening when we do manual therapy. I learned manual therapy as specific techniques. We now know it's not probably exactly I'm moving C3 on C4, but you're providing alternate input. And if that's perceived as being safe and consensual with the patient, then it can have a positive outcome, even just temporary in that moment.
Yeah. And how about exercise? Does it play a role on that as well?
A huge role. We also know that nociceptors are responsive to movement. And a huge thing with our patients is fear of movement. And therefore, changing the way we move. I had a patient yesterday, and he said, every time I do this, it hurts. Now, he did have an infection in his sternoclavicular joint. He was put on antibiotics. So this is a direct link with the immune system. People can relate to things. When I've got the flu, I hurt more. So again, bringing it back to our topic of the neuroimmune system, people can relate to, all right, I thought there was something structural in my shoulder, but I realized that there's some inflammation going on. The immune system also creates inflammation. So that's another word that we can use. And I would get, if I asked him, move your shoulder, because he's relating shoulder to being painful, he has a challenging time or he feels pain with that movement. If I had him then rotate we can't really see it, but if I had him rotate his body to the right, instead of moving his shoulder to the left, I would rotate the left side of your body to the right. And he said, yeah, I see. I said, we're hijacking the system a little bit, meaning that the position is the same, but the way we've gone about moving is different. So we can use movement and therapeutic exercise in a way to help give that joint a sense of safety in movement. I'll give them the analogy of imagining that instead of moving your shoulder on the body, think of moving the body on your shoulder. Mm-hmm. Or starting from the feet. If we move and start to bring our attention or awareness of focus away from the part where they feel pain, often they can move more freely. Because the patient will be like, well, when I don't have pain, then I can move. Mm-hmm. And explain pain or looking at it this way is, well, let's see how we can move a little bit differently.
Yeah. So you don't move directly that part, but you're moving indirectly.
Yeah, indirectly. Yeah. And the word very manipulate smart. Means to move. We're moving something and we're moving in a different way. And then the extension of that is then helping them to feel safe to move when they're not with you. And you say, right, well, let's give up some strategies. And that's where the education piece comes in. And I might ask the patient, get them with a pen. I say, right, can you write down the cues that worked for you? So if you think about an exercise, instead of saying squat down to do a squat, I might say, try and reach your arms forward, bring your buttock back, or use an external attention of focus, meaning push your feet into the ground. So I'm getting them to become aware of their feet. It's giving them stability, grounding. Can you see how we're just giving different cues, and that can often help them to move in a more comfortable and pain-free manner. And look, many therapists probably already do this, but you can think about it as you're providing different input and you're reducing perhaps the threat value of the movement and changing cortical activity at the same time.
That's so crazy to think about that, like words as input as well. Like
absolutely, it's auditory input, and words are incredibly powerful. Think about how many patients said, the doctor told me never to bend. So even thinking of bending is already going to put their system on guard. It's bone on bone. They remember these words, particularly if a doctor or someone of influence has said that to them.
And how we can use that to change the negative experience. You can use positive words to make their experience better, more positive.
Absolutely, yeah. My dad used to say, turn your scar into a star. Like, we can make it positive, but we know that there's actually words can be inflammatory. In English, there's an expression, that those words were inflammatory. Well, there was an interesting study done on social evaluative threat, meaning that when someone was shamed in front of a lot of people, if they measured their pro-inflammatory cytokines, their interleukin-10, their prostaglandins at that moment, you would see an elevation or an increase. So when we feel under threat, we have increased levels of inflammation. Words are very powerful.
Like you are thinking about your presentation.
Yes.
It's crazy. Even like you that have all the knowledge, and like it's something that we just experiment. It doesn't matter.
I'm a human being. I'm not immune from this.
Yes.
I have doubts.
Yes, I was reading that paper. It's crazy, like how they could measure that if you are like under social stress, tension.
Yeah. And there was another one I think I sent you in terms of when they had a group of people that were in a mock mission, and when that mission failed, compared with when that mission was a success, their inflammatory markers went up. So that suggests in the clinical setting, if we set our patients up to do something that they might fail at, that can actually have an inflammatory effect. So the importance of little wins, getting them to move, getting them to see little progress, little changes can make massive differences. And that's how we tie it all into practice. What's that?
And acknowledge them, like, if
course.
Give them little wins and just motivate them.
And they might say, oh, that's nothing. They might say, oh, that's nothing. I said, well, to you it might be nothing. But to those little cells in your elbow, that's everything. They've just had a little win. They feel like a part of your team again. So I frame it. I said, and then I'll say, look, I understand. This is nowhere near what you're capable of. But we need to break out of this pattern, this learned pattern of behavior, and this learned doesn't mean we're not addressing the tissues or there's something wrong with an injury, but we're at least getting your body to work in a more optimal and efficient manner with a positive spin.
Yeah. And so like treatment-wise, we just talked a lot about exercise, manual therapy, education, breathing, mindfulness, like the words that we use, all of that. Anything else that we haven't talked about treatment, something that you use that you think it's important to talk about?
Well, I think education. I think, increasing knowledge or having the patient understand it. So it's one thing to give them the manual therapy or the exercise, but often you're still prescribing this to me. You're doing it to me. Whereas if you can give them that inherent knowledge and say, right, I'm giving it, and they say, oh, wow, I feel much better. I said, well, think of it as a gift. Now practice that gift and make it better so that next time I see you, you can do more things. Use it now. Be creative with it. So I get them to enhance that experience. I'm not really doing anything much different from, what we traditionally think of as physiotherapy or physical therapy.
Mm-hmm. Yeah.
But the idea is then to give them, bring it back to their goals and pace as well. Because also too, the other side is when they start to feel better, then, oh, well, now I've got permission to move. And then their muscles, their joints aren't used to it. And then everything tightens up, or they get inflammation, they have latent pain, and then they're blocked again. And again, goes back to the way of thinking, I overworked, I overpushed, I overdid it. So checking in with a patient afterward or having them pace, don't race. All right, I know it feels good now. At the same time, you've told me in the past that you have pain afterwards. So I want to make sure that we keep you on the right track. So setting boundaries for the patient, staying positive and giving them a clear path. We don't have to get all this done today.
Mm-hmm. Educate them on a gradual progression.
Yeah.
Yeah.
If exercise were a pill, it would be the most lucrative pill in the world. Like, just exercise is really useful. However, if we message exercising in a non-helpful way, it doesn't help our patients, meaning that if it's a threat for them or if they've had in the past, their prediction is every time I exercise, I get worse. Then even using the word exercise can be inflammatory.
Yeah, very interesting. And going off topic, how about music? I saw that you sent me something.
I
Do you have
love
any?
music. Music is a passion of mine. Well, music has been studied a lot in the last 20 years. Music, I use that in practice. So, when we hear a song, you're changing the input again. You're changing auditory input. If it's an old song that they loved, you're also getting them you're changing, having physiological responses. You're changing mood. We know that there's a link between, our thoughts and our emotions and immune health in the gut or sensitivity. When we're in a ramped up sympathetic state, our blood moves to the muscles and moves away from our gut. When we're in a calmer state, we get better blood flow to the gut. So there's also links there, which we don't have time to go over everything, but music can be a really powerful way to help someone calm their nervous system down and even to move. If we think about what happens when we hear a song that's upbeat that we love, we want to move to it. Our body wants to move to it. And incorporating dance and music into our treatments can be really powerful and effective. And I treat musicians, and musicians have an easier time understanding making small changes can change an entire mood of a piece. If you're a musician and you understand scales, for example, there isn't that much difference in the tonality between a happier sounding piece and a sadder sounding or melancholic sounding piece.
Very interesting. And just a quick
that's my passion subject. I could go on forever with that. But
I thought that was so interesting how we can change those things with music as well. So I just thought about asking. Just one quick question before we go to the final questions. When you have that inflammation phase, is there anything in particular that you recommend when you have that inflammatory stage?
Well, I think it's important to realize that just happens. We can't think our way out of that inflammatory state. We can say, it's not mind over matter. It's literally, we have to view it as a process rather than as something bad. We have to say, right, now I can do some breathing. When I do the deep breathing and I visualize it, that can help. It's giving them a strategy that they can use to help then. It's very normal. It's a normal reaction. You go into pro-inflammatory and then anti-inflammatory. That's what happens. That's healing. So then allowing themselves to get into that anti-inflammatory state. And then proactively, I think I might have sent you a paper on, when people that do mindfulness, there was one study with mindfulness, breathing and cold immersion. So graded exposure to stress helps people recognize stress and respond to stress in a better way. So that if they're exposed to, say, a virus or an adverse situation, their body can create an innate immune response and then settle down very quickly. So doing some immune boosting behaviors proactively can be a way through this as well.
I saw a documentary one time. I think it's the Iceman. I don't remember the name.
Wim Hof,
Yes, very interesting. Is that related to the exposure to cold that you're mentioning? A little bit,
yeah. I mean, his work is being studied too. So there are more sort of good, higher level evidence as well. Yeah. But you just got to be a little bit careful. That just doesn't mean you should go out in the cold and
jump on the freezing lake. Yeah. Okay. Look, anything else before we transition to our final questions?
No, I'm open. Yeah, I would encourage you to. There's a lot out on YouTube on this. Neu Group, where we obviously I'm with Neu Group, but we have resources. I would encourage people to learn more a little bit, and there's often free things on YouTube as well as books and things as well.
That was going to be my first question. Resource you recommend? So going to YouTube, going to the Neu Group website. Anything else?
Yeah. there's another book I like that's not Noi Group. It's why do what's it called again? I forgot the name. Mental blank. Why don't zebras have ulcers? Because it talks about the anxiety around pain. And thinking of people don't want to say I'm anxious, but it just means anxiety is just a lot of disorganized neural activity. And that was a good book, but explain pain. There's a new book for clinicians we have out called Bodily Relearning, which talks a lot about the neuroimmune piece in a very practical way with a lot of pictures. So I know I'm plugging another Noi Group publication, but that's another new book that's come out and written by Ben Boyd, who's a clinician in the US as well. So
very good. And last question, any advice to clinicians that are starting their careers?
Try it, okay? Be open-minded. We are asking our patients to listen to us. We are asking our patients to challenge the way they think about their pain. So I encourage every clinician to not move away from it when you're confronted with a challenge from a patient. Engage in dialogue with them. Don't just jump in and try and tell them this is what is wrong with you. Step back, literally, physically, and just listen to their words. Nothing that they say is irrelevant. Our job is to learn more and to help work with the patient to get them feeling comfortable and give them the best opportunity to move more. So, be creative and have fun. Everyone's going to be a little different. I've got a different approach to someone else, but just, really go for it. Have the courage and you'll be amazed.
And try to understand what they are really trying to say with what they are saying, right?
I beg your pardon?
Try to really understand what they are saying, what they are really saying with the words that they are using.
Yes,
so like what they are
that's
communicating.
A great way to, yes. Because there's the verbal and I often ask them, I ask a follow-up question, what do you mean by that? I know what it means to me. What does it mean to you? We might have different definitions, particularly if there's a language barrier.
Yeah. Look, if anyone wants to learn more about you and your work, how they can find you?
You can find me at Noi Group. You can send an email, Luke@Noi Group. Sometimes I'm a little bit delayed at that, but you can always go to headquarters and they can track me down. But please, I'm very, I love helping clinicians understand this more. The more we can practice it, the better we can create a shift in the understanding of pain in the greater community.
Absolutely. That's the goal of the podcast.
Yep.
So
perfect.
Hopefully are reaching more PTs.
Excellent. Well, thank you very much, Mariana.
Thank you so much. I appreciate you taking the time to come here and share all this information with us.
Great. Thank you.